Our next topic is placenta accreta, percreta, increta. If placenta previa occurs over a previous uterine scar, the placental villi may invade beyond Nidibux layer, resulting in placenta accreta. Nidibux layer is a layer of fibrinoid degeneration which separates the superficial layers of the decidua basalis from the deeper layers of the decidua basalis. The placental villi normally will invade in the superficial layers of the decidua, but should not go beyond Nidibux layer. If they do, those villi can go deeper than they should, the placenta will fail to separate, and we have placenta accreta. If the villi invade the deep basalis layers, but not into the myometrium, we call that placenta accreta. If the placental villi invade partially through the myometrium, but not all the way through, we call that placenta increta. If the placental villi invade all the way through the myometrium into the serosa or the bladder, we call that placenta percreta. Let me see if I can show you this in a more specific form. This is my little cartoon here. This is the uterus down here. We have the superficial layers of the decidua right here. We have Nidibux layer, which is the red. We have the deeper layers of the decidua, which are in blue, and the myometrium is here. The normal placental implantation will go up to, but not through, Nidibux layer. This is normal implantation. If there is a break in the Nidibux layer, which may be because of a previous uterine scar, these placental villi will have a channel through which they can invade deeper. And if they go into the deeper layers of the decidua basalis, but not through into the myometrium, we call that placenta accreta. And if those villi go deeper into the myometrium, now we call that placenta increta. And if they go all the way through the myometrium into the serosa of the bladder, it is placenta percreta. This is a histologic section of the trophoblastic villi here, immediately adjacent to or invading myometrium. This is your classic histological conformation of a placenta increta or increta. This is an artist's conception of how this should look. Here is the placenta, and you can see this is the deeper layers of the basalis. The placenta does not go down through that. If the placenta goes through the deeper layers of the basalis, but not into the myometrium, we call that placenta accreta. That's the most common. If the placental villi go into the myometrium, but not all the way through, we call that placenta increta. That's a little less common. And the least common is if they go all the way through the serosa or into the bladder, and we call that placenta percreta. This is a photograph of a uterus, a hysterectomy specimen, which shows the placenta which is invaded into the myometrium such that you cannot separate it. This is a MRI showing the uterus, and you can see here is normal myometrium, and this is placenta which cannot be removed, and you can see how the placenta has invaded into the myometrium here. Now this woman was treated with methotrexate, and here is her subsequent MRI, and you can see that the myometrium looks pretty good. Now she's fortunate, because most of the time, if you have a placenta accreta or increta, it requires a cesarean hysterectomy. Here you can see is the internal cervical os, the external cervical os. Here we have the placenta previa. You can see it right across the cervix. But what's happened over here is the placenta has invaded into the myometrium. It's gone all the way through the myometrium, and in fact invaded into the detrusor muscle of the bladder. And we've had patients who come in with gross hematuria, and they have a placenta percreta. This woman's going to have not only a cesarean, she's going to have not only a hysterectomy, but she's going to have part of her bladder taken out, a partial cystectomy. Fortunately, the bladder is able to respond pretty well and function reasonably good even after that. Here's a good board question. 23-year-old gravida 1 para 0 at 35 weeks gestation has a fetus in transverse line. Now, we already talked about this. What should you consider as a possible cause? Abruptio placenta, placenta previa, spina bifida, or gonadal dysgenesis? And the answer is placenta previa. Consider that. And how do you make the diagnosis? Ultrasound. All right, I'm going to change the situation just slightly. 23-year-old gravida 1, para 0, 35 weeks gestation, is noted to have a fetus in breech presentation. Which of the following should be suspected as the cause? Breech babies are seen more commonly with a uterine anomaly. If you have a didelphys uterus, if you have a uterine septum, the fetus is going to have its feet where it has the most room. And most room in the uterus is in the fundus of the uterus. If the fundus of the uterus is either limited because of a septum or because of a uterine anomaly, the fetus is going to have its feet down and it's going to be in a breech presentation. That would be a great board exam question. This is a hysteroscopic view of a uterine septum. It's a rather thick one here, and this could be resected using a hysteroscope. All right, here's another board question, and don't have a knee-jerk response here. 21-year-old gravida 3 para 1 AB1 at 34 weeks gestation has painful third trimester bleeding. She had a past history of placenta previa. Now, yes, she had a past history of placenta previa, which makes her at higher risk for placenta previa with this pregnancy. But you must pay attention. This is painful third trimester bleeding. The most likely diagnosis is not placenta previa, but is abruptio placenta. And that leads us to the end of placenta accreta, percreta, increta.